So now we'll move on to another friend of mine, Dr. Barry Freedman, who doesn't like to necessarily acknowledge his New York roots, but he is in fact a New Yorker. Dr. Freedman is currently the John H. Felds III Professor of Medicine and the Chief of the Section of Nephrology at Wake Forest University School of Medicine. He's also the Chief Medical Officer of Health Systems Management, Inc. Dr. Freedman received his MD from SUNY at Downstate here in Brooklyn, and then completed his internal medicine training at Eastern Virginia School of Medicine, and then trained in nephrology at Wake Forest. His research focuses on identifying the genes underlying the complex kidney and cardiovascular disease and population-based disparities in kidney disease. His work paved the way for the identification of the apolipoprotein L1 gene, APOL1, and associated kidney diseases. He's now leading the NIDDK APOLLO-U01 Consortium Coordinating Center, evaluating the impact of APOL1 gene variants on long-term kidney transplant outcomes. He's published more than 600 peer-reviewed manuscripts and editorials, and is really a terrific person in addition to being a leader and a scholar of kidney disease. So, Dr. Freedman, thank you for joining us today.
Jeff, thanks. It's a great honor to participate in this Rogosin Institute Symposium, and thank you so much for the invitation. So as Jordan finished up with on APOL1, we're going to take off with that from here. I hope you can all see my slides advancing. These are my disclosures. And today's talk is very clinical. It's patients you might see, the role of APOL1 in transplant, and novel clinical trials that you can enroll your patients in today. So I just want to start like I would with the grand rounds of a 40-year-old African-American woman who sent to nephrology because she has high blood pressure and was recently detected to have stage 3 chronic kidney disease. Her serum creatinine is 1.38, which doesn't excite many primary care doctors, but if you plug her numbers into the CKD-EPI non-race-based equation, she's already lost half her kidney function. Her GFR is 50. She has a normal urinalysis with no blood or protein, and she's treated with an ACE inhibitor and thiazide diuretic for high blood pressure. She's a teacher, doesn't smoke, drink, no illicit drugs. On family history, she has a paternal grandfather and paternal uncle on dialysis, but not much more known than that. And her exam's normal, except her blood pressure is 140/88. Lab testing is pretty unremarkable. She doesn't have diabetes, negative ANA, negative hepatitis and HIV serologies, and her urine albumin creatinine ratio is flat normal, 10 milligrams per gram. Renal ultrasound shows bilateral 8.8 centimeter, slightly hyperechogenic kidneys. And if one of Dr. Silberzweig's fellows saw this patient in clinic this morning, they'd come to him and say, oh, we have a patient, they have hypertensive nephrosclerosis. I'm going to raise the ACE inhibitor dose to lower the blood pressure, and this patient's going to do fine. I want to just show you what's going to happen if that's the management. 3 years later, this woman's going to be on dialysis, starting with a GFR of 50. And the true diagnosis in this case is not hypertensive nephrosclerosis. It's APOL1 mediated kidney disease. And tips are the family history, but many people don't even have a family history and will prove to have APOL1 kidney disease. The difficulty lies in the United States Renal Data Systems network for reporting the cause of kidney failure, and we're working hard to get APOL1 kidney disease as an ICD-10 code, but it hasn't happened yet. So today, 29% of all patients starting dialysis are given the diagnosis of hypertensive nephropathy, 48% diabetes, and we know many of these people just have coincident diabetes or secondary high blood pressure with other causes of kidney disease, but many clinicians don't bother to dig in and check those boxes. In African Americans, more than 35% of patients starting dialysis in 2024 were listed as having hypertensive kidney failure. I'm just here to tell you that virtually every one of those diagnoses is wrong. The only time high blood pressure causes kidney disease is renovascular disease affecting large renal arteries or malignant or accelerated hypertension. Mild to moderate essential hypertension virtually never causes end-stage kidney disease, and if you don't believe me, I'll show you the data in a minute. And this, we all know, African Americans have 3 to 4-fold more cases of end-stage kidney disease, higher incidence rates than all other population groups. The vast majority of that difference comes from two coding variants in the APOL1 gene, the G1 and G2 variants. And, while we're talking a lot about genetics and regeneration, the family history is absolutely key. My children grew up at the dinner table hearing about kidney failure genes every night at dinner. And they saw this ad when we were in Europe for the Brussels train saying, take the train because there's a bathroom. And when my kids were young, they looked at this and said, Dad, this is one of those families with kidney disease you keep talking about. That's familial clustering of kidney failure. Well, this is ancient data from 1993, but it holds the keys and the clues to the APOL1 story. We published this paper in American Journal of Kidney Disease showing these are different African American families. The folks in the solid circles and squares have end-stage kidney disease. Here's a family with a mother had proteinuria, FSGS. One child had no proteinuria and was listed as hypertensive nephropathy. Another child with diabetic nephropathy. 3 different causes of kidney failure in a family. I remember these families. I took care of them. I know these people. Here's a family with 4 people on dialysis, 4 different causes. Chronic glomerular disease, type 2 diabetes, hypertension attributed, type 1 diabetes. Families with HIV nephropathy, lupus nephritis. But we saw many African American families with different kinds of kidney failure in the same family. We didn't see this in any other ancestral population. In a white family, if somebody has type 2 diabetic nephropathy, everybody else in the family had type 2 diabetic nephropathy. Or if it was an Asian family with IgA, everybody had IgA. This was different. And we proposed that there was a single overarching genetic cause of kidney failure in the African American population that could account for many different kidney diseases. And almost every family had one of these people with hypertension attributed nephropathy that had high blood pressure, no diabetes, and low levels of proteinuria. And we said, no, 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 this is not hypertension. This is actually an inherited disease, and that's secondary high blood pressure as the kidneys weaken. This is a series of 4 papers from 1993 to 1999. We looked at those African Americans on dialysis who, for all the world, appeared to have hypertensive nephropathy, low-level proteinuria, no diabetes. And I just asked them, how many of you have relatives with end-stage kidney disease? And shockingly, 40% had a first or second degree relative already on dialysis. These are not relatives with proteinuria or declining GFR. These were relatives who had made it through the excess risk of heart attack and stroke and heart failure and survived to dialysis. So then I found a control group of African Americans with long-standing severe high blood pressure that after many years of hypertension and many smoked, had high LDL cholesterols, multiple other comorbidities, but they had a normal urine albumin creatinine ratio and a GFR above 90. And only 8% of them had a relative on dialysis. The same high blood pressure. If you're from a family with nephropathy, many members have nephropathy. But if you're an individual with high blood pressure and no family and no kidney disease, very few people in your family will have nephropathy. It's the same for type 2 diabetes. 37% of African Americans with type 2 diabetic nephropathy had a first or second degree relative on dialysis. 7% of African Americans with long-standing diabetes, very poorly controlled blood sugars, but they themselves did not have any evidence of nephropathy. Their families, only 7% had a relative with end-stage kidney disease. We looked at lupus nephritis, which you all know only half the patients with lupus get renal involvement. African Americans who had lupus and nephropathy, 28% had a relative on dialysis. African Americans who had long-standing lupus but did not get renal involvement, none of them had a family history of kidney failure. And finally, HIV nephropathy, which at the time we thought this, by the way, was at a time before highly active antiretroviral therapy. We thought this was an environmental disease as you could get. Yet 24.4% of African Americans with HIV-associated nephropathy had relatives on dialysis. We had to work hard to find a group of African Americans with long-standing HIV and no renal involvement in the pre-heart era. But we did, and they didn't have kidney failure. Only 6% had a relative with kidney failure. This 6 to 8% of nephropathy in African Americans with hypertension, diabetes, HIV, that's the background risk of end-stage kidney disease in a typical African American in the United States. 7% of blacks will end up on dialysis in their lifetime, about 2% of whites. So 7% divided by 2%, that's the 3.5-fold excess risk for kidney disease. So what it told us was if you have a risk for kidney disease, many members in your family will have nephropathy, and you're much higher risk with diabetes, lupus, or HIV infection. By the way, the folks who had HIV nephropathy, all the relatives on dialysis were HIV negative. The folks with lupus, their 28% of relatives on dialysis, none had lupus nephritis. This was all this mix of many different types of kidney disease in a single family. And in 1995, we wrote a very big review paper, The Link Between Hypertension and Nephrosclerosis. And we said in 1995, actually, I submitted this paper in 1993, and it was rejected at AJKD. And the reviews were not really reviews, they were more like personal attacks against me. So I went back to the editor and said, can we have a fair review this time? And over a year later, they finally accepted it. Back in 1993, we proposed hypertensive nephrosclerosis does not commonly initiate kidney disease. There were genetic factors causing primary kidney diseases with secondary hypertension in African Americans, and variation in one gene underlied many kidney disease in the African American population. So let me just take you for a moment through trials of mild to moderate hypertension and control and the effects on the kidney. And you guys all remember the Australian therapeutic trial, the multiple risk factor intervention trial, Mr. Fit. So first of all, these were done before ACE inhibitors and ARBs. So I want to separate them for a minute. And then we'll come to the SPRINT and the ASK studies, which looked at hypertensive folks in the ACE-ARB era. But the Australian therapeutic and Mr. Fit accepted patients as having essential hypertension if their serum creatinine was less than 1.5. So that's like the woman I presented to you today. Her creatinine was 1.38, and she'd already lost half her kidney function. Those folks would have been enrolled in the Australian therapeutic and Mr. Fit trial as having just plain old essential hypertension. And nobody excluded renovascular disease. They didn't even look at the renal arteries. So what I'm trying to say is many people in the Australian therapeutic trial at Mr. Fit had marked reductions in GFR or renovascular disease, and those who had a rise in creatinine would overestimate the likelihood of high blood pressure doing it. Well, in both of these trials, the Australian therapeutic trial was an observational study, didn't treat people, left them hypertensive for 3 years, and there were more than 5,000 people in that study. Mr. Fit followed patients for 7 years, more than 10,000 patients, put them on medicine. It didn't matter if you were observed an untreated hypertension or treated. 1 per 1,000 patients in these studies had a rise in creatinine above 2. That's not dialysis. That's just a rise in creatinine to 2. And that included people with intrinsic renal disease and renovascular disease. So this is an overestimate. My point is, mild to moderate hypertensives don't go running to the dialysis unit. That's not a risk factor for initiating nephropathy. Well, let's look at SPRINT and ASK. These are big, multi-million-dollar NIH trials. And Wake Forest was the coordinating center for the SPRINT study. This is a New England Journal paper showing intensively lowering the systolic blood pressure to less than 120 versus less than 140 in 9,300 people was associated with significant reductions in fatal and non-fatal major cardiovascular events and all-cause death. So the primary outcomes of MI, coronary syndrome, stroke, heart failure, or CVD death, all reduced with intensive blood pressure lowering to a target of less than 120. But there was no significant effect on slowing progression of established nephropathy. And if you started with normal kidney function, there was a significantly increased risk for your GFR falling below 60 and remaining there if you started with normal kidney function, but were brought to that very low blood pressure goal. And this is table 2 in the New England Journal paper. Top of table 2 shows a statistically significant 25% reduction in MI, coronary syndrome, stroke, heart failure, cardiovascular death, or death from any cause. Getting the blood pressure down intensively to a systolic below 120 is very important to do, and we should all do it, nephrologists as well as everyone. But this is the top of table 2. Here's the bottom of table 2. The bottom of table 2 said, what about people who have chronic kidney disease at baseline? What happens for the composite renal outcome of a grade greater than 50% fall in GFR, the need for dialysis or transplant in the intensive versus the standard arm. The p-value was 0.76, no significant effect. So in those, and by the way, there were 2,600 people with CKD in SPRINT. They were hypertensive, not diabetic, no effect on slowing progression of chronic kidney disease. And if you started with normal kidney function, a GFR above 60, and by the way, there were 6,600 patients, 3,300 in the intensive arm, 3,300 in the standard arm. They started with a GFR above 60. How many had a greater than 30% fall in GFR to a level below 60 now? They're in stage 3 or higher CKD that persisted for more than 90 days. It was not autoregulation. It didn't get better. Well, there was a 3.5-fold increased risk of declining GFR in those with intensive treatment that was statistically significant. So you're not really helping the kidneys here, but you're making people live longer, preventing heart attacks, strokes, and heart failure. So we should all get the blood pressure down below 120. But don't think you're preventing kidney disease, because you're not. And we had to write a follow-up article in Jason last year just to comfort nephrologists and say, even though this happens, not many people are starting dialysis, and you should be aggressively lowering blood pressure. But getting to APOL1, what about effects in African Americans? That's the population of interest for APOL1. And the African American study of kidney disease and hypertension published their final results in Archives of Internal Medicine. And I love the title of this paper because it looked at progression of kidney disease in hypertensive chronic kidney disease in African Americans. So the title is wrong. These patients didn't have hypertensive kidney disease. The final 10-year results in 1,100 participants was that strict blood pressure control in African Americans with presumed hypertensive CKD failed to slow progression of kidney disease, and ACE inhibitors, calcium blockers, and beta blockers had similar lacks of effect. This is the outcomes of ASK, African American Study of Kidney Disease and Hypertension. And the red line is the group randomized to ACE inhibition with a very low blood pressure goal. And after the first 3 years of the study, everybody was put on high-dose ACE inhibition, and the blood pressures were well controlled. 60% at 10 years had a doubling of creatinine, started dialysis, or died. And actually, very few died. Mostly, it was a doubling of creatinine or starting of dialysis. And what this looks like to me is the progression of any inherited intrinsic chronic kidney disease. High blood pressure control had nothing to do with stopping it. So this was like a $70 million NIH trial. We went ahead and got the DNA from the ASK participants, and we published a paper in Kidney International. Mike Lipkowitz and I were the co-first authors saying, it's the APOL1 gene variants that actually associated with hypertension, attributed nephropathy, and the rate of kidney decline in African American study of kidney disease and hypertensive patients. The large majority of these patients had APOL1 nephropathy, and the APOL1 genotype predicted progression of proteinuria and loss of kidney function, nothing to do with blood pressure control. And, this is the landmark paper in Science. Martin Pollack in Boston is the senior author here, first showing the association of APOL1 gene variants with chronic kidney disease in African Americans and protection from the parasite that causes African sleeping sickness. This is Trypanosoma brucei rhodesiense in the bloodstream with red cells around it. And if you had APOL1 G1 and G2 kidney risk variants, you would kill the trypanosome. And you see these trypanosomes have swelling of the lysosome when they're exposed to plasma from somebody with a G1 or G2 kidney risk variant. If you expose a trypanosome to somebody with the wild type variant, G0, that all Europeans, Asians, Hispanics virtually all have, the lysosome is normal, and that's a perfectly happy, healthy trypanosome. So in the United States, 2 risk variants, any combination of G1, G1, G2, G2, or G1 and G2, you get one from your mom, one from your dad, was increase the risk of chronic kidney disease, and it was an autosomal recessive inheritance pattern. Going back to our 1993 observation, we immediately jumped back and said, this is the answer. APOL1 explains this whole spectrum of kidney diseases more common in African Americans. It causes the disease we call global glomerulosclerosis, where there's complete loss of glomerular capillaries. Basically, the glomerulus is a solidified ball with no open capillary lumens, so there's no place to filter protein and get proteinuria. That's why they present with low-level proteinuria and were mistaken as having hypertensive nephropathy. We know 70% of cases of FSGS and collapsing FSGS due to HIV-associated nephropathy, COVID nephropathy, or interferon administration, 70% of cases of these diseases are caused by those two coding variants in APOL1. Sickle cell nephropathy, lupus nephritis, and failure of kidneys donated by African American deceased organ donors and transplanted, failing rapidly. The main reason for failure is APOL1 in those donor kidneys. So now we can understand why many different diseases were present in single African American families. We know that tsetse fly in sub-Saharan Africa with its stinger is a reservoir for the Trypanosoma brucei, and in this case, rhodesienza infection. It can sting African individuals in sub-Saharan Africa. There's a canker sore injecting the trypanosome in, and if this individual lacked G1 or G2 risk variants, they'd be much more likely to die of African sleeping sickness. And some 8,000 years ago, when these G1 and G2 mutations first occurred, nobody on the planet Earth had a G1 or G2. But very shortly thereafter, they were so protective from African sleeping sickness that millions perished, and those with G1 and G2 passed them on to their offspring. And now these are very common variants in African Americans, Brazilians, Afro-Caribbeans, and throughout sub-Saharan Africa. And it turns out APOL1 is the strongest genetic cause of any common complex disease, just happens to be a kidney disease. And if I walk into a dialysis unit in Manhattan, in Winston-Salem, North Carolina, Chicago, Los Angeles, or Birmingham, Alabama, doesn't matter. If I went into any dialysis unit in those states, 1 in 3 African Americans on dialysis, no matter what is written in the chart, they are on dialysis because APOL1 caused their kidney disease. Maybe they're listed as diabetic nephropathy, but more than 20% of African Americans with diabetes have other causes of kidney disease. Diabetes is very common, and they may as well have APOL1 mediated FSGS with heavy proteinuria. You need to do the genotyping to tell who has the disease. And although nobody on Earth had a G1 or G2 risk variant 8,000 years ago, today in African Americans, 13% have 2 risk variants with markedly increased risk for kidney disease. 39% have 1, meaning they're a carrier and they can transmit that variant to their offspring. 52% have at least 1 copy. That's 2 variants that didn't exist 8,000 years ago. That is how strong the selective effect was. APOL1 is only found in higher level primates, humans, gorillas, and baboons. So every grant I wrote that was rejected because somebody said I have a great rodent strain of hypertensive kidney failure in humans and I can find the gene, but nobody can find them in people would be wrong because APOL1 gene isn't in rats, mice, sheep, pigs. It's not in anything but higher level primates. You had to study those populations to find it. Other populations without sub-Saharan African ancestry lack these variants. So if somebody says, well, there are Hispanics from Brooklyn that have G1 and G2, well, they're admixed populations like Puerto Rican populations, Dominican populations that have admixed with African ancestry populations, and that's where the G1 and G2 came from. About 15 to 20% of individuals with 2 APOL1 high risk variants will get nephropathy. So there's obviously modifying factors like HIV, COVID, anti-nuclear antibodies, interferon. But the interesting thing is 70% of cases of FSGS and HIVAN would go away if the G1 and G2 risk variants didn't exist. You know, the risk for non-diabetic chronic kidney disease would approach equity 1-to-1 in blacks and whites if APOL1, G1, and G2 variants didn't occur. And I was taught back at downstate medical school that FSGS was not a disease. It was a histologic scar. Many different, hundreds of diseases could end up in a pattern of FSGS. And that's very true in everybody but African ancestry populations. In African Americans, 70% of FSGS is due to APOL1. It's a single disease. And you all know H3 Africa Consortium, big breakthrough paper in the New England Journal of Medicine. Matter of fact, our group did all the genotyping for H3 Africa. In Africa, one risk variant increased the risk of chronic kidney disease. You didn't have to have two copies like the United States. And I think part of this may be different environment in Africa, but I also think part of it is a selection effect because many people in Africa with two risk variants likely perished because dialysis is not so widely available, and that may have shown a magnifying glass on those with one risk variant. But be that as it may, one risk variant increases risk of kidney disease in Africa. I mentioned modifying factors. This is a very big breakthrough in the last couple of years of a gene-gene interaction. There's a protective APOL1 variant called PN264K. It's not that common, but if you have one protective invariant and a G2 variant, the protective variant nullifies the G2. So we know of gene environment modifiers like HIV and COVID and interferon administration. Now we have a gene-gene interaction, and these go into explaining why only about 1 in 5 people with a high-risk genotype gets kidney disease, these modifying effects. So we consider genotyping in transplantation, and as Glenda Roberts told you about, we're all working on the APOLLO study, and I'll give you a little bit of an update on that, but we're looking at the effects of APOL1 genotyping of deceased organ donors on transplant outcomes and the safety of living donation in African Americans. We think that there are many patients with non-diabetic and diabetic chronic kidney disease who could be entered into clinical trials if they're found to have APOL1 nephropathy, maybe a role for genotyping. Patients with HIV infection, lupus, sickle cell disease, especially if they're not compliant to their therapy. If you can tell them they have an APOL1 high-risk genotype and they're at high risk for nephropathy, maybe they'll be compliant to treatment and for family planning purposes. But just a moment about the APOLLO study. It's been known for many years that in deceased donor kidney transplantation, if you get a kidney from a donor of African ancestry, that kidney is going to fail more quickly than if you got a kidney from a deceased donor of other ancestral populations. So European, Asian, Hispanic, all those donor kidneys function longer and don't fail as quickly. And it doesn't matter the ancestry of the recipient of the kidney, it's the donor. Well, once the APOL1 discovery was made in 2010, that we worked on with Martin Pollack, we said, it's likely APOL1 is causing this effect. This is a paper from 2011, 1 year after the Science paper, where we showed that in a single center study from Wake Forest, these are all African American deceased donor kidney transplants, 136 transplants. Those donors that had two APOL1 risk variants failed very quickly. African ancestry donors who had 0 or 1 APOL1 risk variant, those kidneys lasted just fine. Matter of fact, their outcomes were similar to kidneys donated by European Americans. So it wasn't that these were African American deceased donor kidneys, it's the fact that they're APOL1 high-risk donor kidneys. And for the longest time, race was used in kidney allocation by the KDRI, Kidney Donor Risk Index. If you got a kidney from an African American donor, the quality was downgraded, and we think that makes those kidneys more likely to be discarded. In fact, 87% of those kidneys are fine. It's the 13% with a high-risk APOL1 genotype that carry all the risk, and we look at those as like expanded criteria donor kidneys. They should be donated and transplanted into people who maybe don't need the kidney to last as long because they're older with more comorbidities. I should also tell you that this paper was in AJT, the best transplant journal. It was initially rejected. I called the editor. I said, this really is an important paper. He said, yeah, I think we made a mistake in your review. Let me get it re-reviewed. It finally was overturned and published, and it's been cited more than 300 times, and it led to the $50 million NIH consortium that Glenda and I work on. This is a follow-up study we did. People complained our other study was single center. This is 103 transplant programs, 600 donors, 1,100 transplants, and you can see that if you got an APOL1 high-risk deceased donor kidney, you are twice as likely to have graft failure at 6 years than if you got a kidney from an African American with a low-risk genotype. So APOLLO is likely to change organ allocation and provide a lot of information on the safety of live kidney donation in people with African ancestry. And I think APOL1 genotyping of living donor candidates will increase donation in this population because many are afraid to donate. Many in their family have nephropathy. And if you can tell them, well, you probably have a family where there's a lot of APOL1 kidney disease, but you do not have an APOL1 high risk genotype, we think it's much safer for you to donate. I think a lot more people will step up and donate. And then I'm going to end with the exciting novel therapies that are coming around now. And when you have a genetic disease, there's many ways you can intervene. You can do CRISPR, Cas9 gene editing, which we're nowhere near for APOL1, but you can affect the APOL1 messenger RNA and change the amount of protein made with an antisense oligonucleotide, which is in a phase 2 trial, or you can use an APOL1 protein small molecule inhibitor, allowing the protein to be made, but blocking its effect on the receptor, and that's in phase 3 trials already. So when you have DNA in a gene and you want to transcribe it to a protein, you can allow the protein to be made like APOL1 protein and use a small molecule inhibitor that blocks its effect. You can take the APOL1 messenger RNA in the nucleus and cytoplasm, and you can break it down, which then leads to reduction in APOL1 protein synthesis. And we know it's the protein synthesized in cells of the kidney that is what causes nephropathy. Or you can block cellular processes that increase APOL1 protein message, like JAK-STAT signaling using baricitinib. And there are trials that are enrolling participants right now, all registered in clinicaltrials.gov for all three. I want to show you the biggest trial that's out there so far, the inaxaplin study by Vertex Pharmaceuticals. This is New England Journal of Medicine. Inaxaplin for proteinuria kidney disease in people with 2 APOL1 risk variants. They had to have biopsy-proven FSGS and more than 700 milligrams of protein a day. The APOL1 protein is made, but inaxaplin binds to the receptor and blocks its effect. And amazingly, in 13 weeks, there was, a 44% drop in urine protein creatinine ratio in people getting inaxaplin, even though they had biopsy-proven FSGS with structural lesions. This is extremely impressive data showing ongoing damage in the kidney, even though, FSGS is there. If you block APOL1 protein, dramatic reductions in proteinuria. I was surprised how quickly the proteinuria dropped. It's very exciting. And not only is there an inaxaplin in a phase 3, there's another drug by Maze Pharmaceuticals, a small molecule inhibitor out there. And there's an antisense oligonucleotide, which blocks messenger RNA. I told you mice don't have an APOL1 gene, but if you give them the G0 variant and in a transgenic model and turn it on with interferon, they don't get kidney disease. If you give them G1 or G2 and you turn on the gene with the interferon, they get proteinuria and FSGS. So we can create a transgenic mouse model, and in that model, if you gave an APOL1 antisense oligonucleotide, it blocked the proteinuria. So this is the APOL1 G1 transgenic mouse. G1 is a kidney risk variant. If you turn it on with interferon, look how much proteinuria these G1 mice get. If you turn it on, but you give them a control antisense oligonucleotide, not against APOL1, proteinuria goes way up, and the antisense oligonucleotide did nothing because it's not directed against APOL1. But if you give this transgenic mouse with G1 risk variants interferon to upregulate APOL1, but you give an APOL1 antisense oligonucleotide, no proteinuria develops, completely blocked. So in an animal model, we can show this APOL1 antisense oligonucleotide prevents development of kidney disease. There's a human trial, a phase 1 study of the same antisense oligonucleotide. It's called AZD2373. 32 healthy volunteers got it in 3 treatment cohorts. And I want you to see those that got the low dose had a fall in plasma APOL1 levels, medium dose, a greater fall, higher dose, a largest fall. And when you stopped the antisense oligonucleotide, the protein in the bloodstream goes up. We also know that in those mice, not only did the protein drop in the bloodstream, it also dropped in kidney sections because those mice were euthanized who got this antisense oligonucleotide, and it could be shown that APOL1 protein was reduced in the kidney too. So finally, there's now a phase 2b study by AstraZeneca, the Appreciate study, and I mentioned all my conflicts. I have funding from AstraZeneca, and Wake Forest and I lead the AstraZeneca Appreciate antisense oligonucleotide. and it's being given to 96 people with APOL1 kidney disease in the United States and United Kingdom. So I just want you to know that if you can recognize family clustering of kidney disease and recognize high blood pressure is not the cause of kidney disease, you can change medicine. The Apollo study is going to optimize kidney allocation and look at living donor safety. And now these new treatment trials are out there looking at APOL1 treatments in many aspects. So we now have therapies for a genetic disease. Whoops. Take home message: two coding variants in APOL1 directly cause a spectrum of non-diabetic chronic kidney diseases in African Americans, solidified glomerulosclerosis, which is misattributed to high blood pressure, FSGS, collapsing glomerulopathy, lupus nephritis, sickle cell nephropathy, and failure of transplanted kidneys from APOL1 high-risk genotype donors, and directed therapies against APOL1 protein, messenger RNA, and signaling pathways are in clinical trials and provide great hope for our patients. Thank you for your attention.
Barry, I can't thank you enough. That was a really terrific talk, and you sufficiently dumbed it down, even for those of us who don't know anything about genetics, so I appreciate that greatly. I know you have to go shortly, so I do have a couple of questions that have come in. Can you first share any data regarding the outcomes of patients with APOL1 mediated disease who were receiving kidney replacement therapy and transplantation? How do they do? Does the APOL1 gene variant affect how they do?
Great question. So APOL1 causes renal limited disease in this solidified glomerulosclerosis FSGS spectrum. Dialysis patients on in-center hemodialysis, peritoneal dialysis, live longer with APOL1 because they lack this atherosclerosis and disseminated diabetes. So we have that data. In transplantation, most studies, 7 out of 8 studies showed the recipient genotype has nothing to do with it. There's one study bringing that into question, but there are flaws in that study. Apollo is looking at about 3,000 recipients based on genotype and will answer the question, but it's more the donor kidney and transplant that affects outcome, not the recipient's genotype.
Got it. And I don't want to get you in trouble, so if you can't answer this question, just tell me that. But can you speak to the impact of the proposed reductions in NIH funding, not only on the basic science research, the type of work you've done, but further on our understanding of kidney disease and the ability to treat it?
I think that's a panel question and it doesn't directly relate to APOL1, so I really can't answer that.
Okay, I appreciate that. I do know you have to go. You have another meeting at 3, so I appreciate your joining us today. And if I could ask the other speakers to turn on their cameras, we'll move on to questions for the rest of the panel. Thanks again, Dr. Freedman.